Good evening and welcome to tonight's live, where we're going to be answering your questions about early pregnancy, which is such an exciting time, but can also be filled with a lot of nerves and anxiety. What's normal? What's not? It's often new, especially if it's been some journey to get here. So joining me tonight, Joseph Sgroi, who is coming in now. He's an obstetrician, gynecologist, IVF and infertility specialist. He's a committee member of the Royal Australian and New Zealand College of Obstetricians and Gynecologists and the RANZCOG Women's Health Policy Committee, which aims to improve the health outcomes of women, couples and their babies. And I think, was that coming through now? Yeah, I've come through. How are you, Joe?
Very good. How are you, Tasha?
I was just giving you a big wrap of an introduction.
Thank you.
So I know I always start by saying this with you, but I love your journey to get here. I love your passion for women's health, for fertility issues and for early pregnancy that we're talking about tonight. So for those who don't know your journey to get here, what inspired you to work in the field of obstetrics?
I think one of the first things to say actually that is I always wanted to be a doctor, and to be honest, I didn't really know what being a doctor was because when I was a young tot, the GP, the late great David Thomas, who also was fortunate enough to bring me into the world, was a great man, but and I knew what a GP was. I was born at St George's Hospital in Kew, and which is now an aged care facility. But through my training at Monash Uni, where I did my medical degree, I was very fortunate enough to be able to be involved in the pregnancy journey of a woman and subsequently in the birth of her child at St George's. And I was one of the last women who actually gave birth at that particular hospital. And I think not only her encouragement of me, and I'd love to know I can't remember who she is, yeah?
Yeah, she's
But,
listening, please let us know.
Who knows? I mean, it was, back in 1996, she would have had her baby. But, she was so encouraging at a time when, particularly as a male medical student, it was very difficult to be able to even experience a birth with a woman. And because women, naturally enough, probably want to be surrounded by women at the time that they give birth, and a male medical student, really, it was a lot difficult. And the midwives, to be honest, probably made it a little bit difficult for us as male medical students as well. But anyway, this woman was exceptionally encouraging, and was not only that encouraging, she really wanted me to catch her baby as well. And it left a really strong and an emotive. It was an emotive experience, and also I found her to be quite empowered by the whole birthing experience. And I suppose my limited role in being able to support her and care for her and help her through that journey was, rewarding not only for myself, but also she also saw it as something that was quite special as well. And she gave me a card, and she was exceptionally thankful for the care that I gave her. And look, then afterwards, I ended up graduating from medicine, and I went to the Alfred Hospital, and I was on the journey to becoming a cardiologist. And save for the fact that my wife and I had our first child, Kiara, and that I really again sort of just reconnected with that whole sense of pregnancy and women's health. I mean, there was a time where I was a medical registrar and working in emergency, and if any woman came through emergency with any pelvic floor issue, bleeding, I'd leave the card and say, it's too hard for me to do. I'm not doing that, right? To then really feeling that it was partly my calling. And so I left. I have to, in advancing my career towards cardiology, left to what I thought was my true calling, and I'm glad I did, in obstetrics and gynecology and fertility medicine. And look, there's not a day that I don't get up first thing in the morning and relish the opportunity to be able to work. I mean, I start my every day at 7, and I just got home 20 minutes ago quickly, and dinner, and now speaking with you. So, and I may be up tonight catching a baby. But the opportunity to be able to combine not only a medical understanding. So using all my medical skills that I learned in physician training, an understanding of endocrinology, so the way hormones work, being a medical doctor in terms of fertility medicine, but also being using my hands, being able to do laparoscopic surgery and help women with endometriosis and help them with their chronic pelvic pain. Being able to help women and couples with respect to their fertility journey through IVF. And then finally being able to care for someone during pregnancy, not only the woman, of course, but her partner and extended family for that matter, and of course the baby. And so I can't, it's quite an emotive job in so much as I am involved in that whole, there's a woman today who came and saw me, and we've been fortunate enough to go through 2 pregnancy journeys and the birth of 2 children. And, it's been 5 years of this relationship, this professional relationship that's come to an end. And, you do get emotional about that stuff.
Yeah. Look, that's exactly why I send patients to you, because you do have that care factor, which can't be taught. That's not taught in medical school. You have that attachment to your patients and their outcomes for their partners, their families, and creating families. So yep. I'll allow you to...
Sorry.
No, it's wonderful. I said it is literally why I send you so many patients, because I know you are there, and you always say that you are there for their birth, you are there for when they conceive, and you are there to catch their babies. And take your time. You're getting lots of hearts here, by the way.
Yeah, I mean, there are difficult times as well. Like, today a woman who she pregnant through IVF, and 16 weeks we find there's not a baby's heartbeat, and there's stuff that's not great. But as well as that, you've also got to work through that as well, and try to help people at a very difficult and vulnerable time. And I think women are particularly vulnerable in terms of their emotion, through fertility and through pregnancy, and to be able to support them is it is a humbling and a privilege.
Yeah. Well, it is amazing. You get lots of amazing comments here, so please look through it when we finish. And It is a privilege to send my patients to you, who get the ultimate care from the time they walk in the door, I've heard it before, to the time they walk out with their baby. And you definitely do have that care factor. And being here tonight to share your expertise and allow women in this nervous time to get their questions answered, which is really blessed to have you as our specialist. There's lots of beautiful comments coming through. So thank you for taking your time out of obviously what was a very busy and emotional day for you today. Yeah. So if anyone has any questions for Jo, please send them through. I have had a few emailed through to me earlier, because I know everyone wants to speak with you and get information from you about their pregnancies. So we might start off with a few questions. And if you need a break, let me know. You've been through a lot tonight. I'll just check if there's any questions that have come through. Okay, there's a few. Look, there's mostly lovely comments coming through. So we'll start off with a few questions that have come through at the moment.
Sure.
A few basic ones to begin with. Exercise is one you probably get asked a lot, but particularly I had 2 questions on F45. Seems to be a popular topic at the moment. What do you recommend? Is it okay in early pregnancy? Can they continue their F45? What's your opinion on that?
In terms of pre-pregnancy, of course, I think it's important to maintain good physical activity. And you should enter into pregnancy also understanding that, women, the whole pregnancy journey and even the labour itself, I mean, it is running a marathon. And the fitter that you are as you move into pregnancy, the better you're going to stand instead in terms of your own health and also the baby's health throughout the whole pregnancy journey. And moreover, in terms of also the birth experience itself. So, being able to push and have that, being able to have the oxygen capacity to be able to withstand the rigors of labour. And there's no doubt that women who maintain a good element of cardiovascular fitness will have a really good positive birthing experience. In actual fact, there are studies to suggest that high impact sort of sport where you're running and you're stressing the pelvic musculature and also the pelvic bone decreases the risk of pubic symphysis diastasis towards the latter part of pregnancy, where women get a lot of suprapubic pain, which is akin to having osteitis pubis. So that's particularly important. I think the difficulty, of course, is that you've maintained this element of physicality before you become pregnant. And then what do you do in pregnancy? Well, you do need to modify the type of activity that you do when you are pregnant, because, of course, there's changes, particularly with the hormones, relaxin and progesterone, that cause a laxity in ligaments. And, of course, your own center of gravity that will change during pregnancy when you have a belly, and the changes to the spine as well. So I think listening to your body, look, I've done F45 and I'm not going to speak on behalf of them, but I felt when I did F45, it was switch on straight away. And I think part of what you do need to realize is that in pregnancy, with those changes, particularly to the ligaments, you want to sort of slowly ease into exercises. So look, my wife is, we've just had another child 2 years ago. She was doing body attack at 37 weeks, 38 weeks, and doing burpee push-ups. And, I was sitting there going, even I can't do a burpee push-up, but you're doing it, right? But she was doing that pre-pregnancy, was listening to her body, and continued during the pregnancy journey as well. So it was not picking something up during pregnancy that would cause her injury.
Yeah. So pretty much if they're doing it beforehand, you can continue some level of reasonable intensity exercise during pregnancy to help keep you nice and fit, but yet don't take up high impact classes if you haven't done them before.
Yeah, and we've got to remember that, someone like Serena Williams was pregnant and won the Aussie Open, yeah?
Yeah. No, it's reassuring to know, I think, when you want to wrap yourself in cotton wool sometimes when it's been a long journey, to know that that's still beneficial. So the other question, we're in Melbourne. Coffee always comes up whenever we chat. So what's your thoughts on coffee? I know mine, but what's coffee and caffeine during pregnancy?
So again, I use the example of if you told all the women in Greece, Italy, anywhere where there's a high coffee consumption, hey, listen, you can't have any more coffee anymore, there would be riots in the streets. And so, look, there's, with everything in moderation in terms of coffee, one could argue that the studies are a little bit poor, and that's the difficulty with anything like this. But I think the safest amount of coffee that you could possibly take is around 60 milligrams of coffee per day, which equates to sort of, one coffee and a bit. Having read the literature and looked at it, the outcomes in terms of pregnancy are, I think if you do any study in terms of caffeine consumption, you're probably going to find that there's confounders with everything, So my personal belief is, if 1 cup of coffee in the morning is what you start your day with, I don't think there's any reason why you shouldn't continue.
Yeah. Now, I usually say to my patients, keep it under 1 and you're pretty safe. It's if you can cut it out, great. If you keep it under 1, you're pretty good. With your
I mean, there's standard things we know that are a no-go. There's no safe limit of alcohol. But, I think, I remember when I was actually taking a little bit of a leave from medicine, and my wife and I were traveling around Europe, and there was this woman we were in France, and there was this woman who was pregnant, eating shellfish. I'm sure she had, liver pate there as well, but she was smoking. She had a glass of wine, she had a coffee, and she was eating soft cheese. Kid you not. And like my wife and I were like, oh God, I can't believe she'd be doing that. But, there was a sense of being a lot more relaxed about pregnancy, obviously from that perspective. Yeah.
So coffee is probably going to be okay. I've just got a few questions coming in here that I'll skip to. Alicia lost her baby over 5 weeks ago. Sorry to hear, Alicia. And she just found out she's pregnant again. Had bloods done on Saturday, 5 weeks after a D&C, and her HCG levels were only 174. Is that too low? I guess talk to us a bit more generically about HCG as well. That's a question I've got here as well.
Yeah, look, I mean, I think HCG at the time that you would anticipate having missed a period, And of course, it's difficult in this situation because we've had a miscarriage, and I'm sorry to hear that, and then had a D&C. But let's say, for example, you've ovulated 2 weeks ago, and now's when your period's due. We would anticipate that the pregnancy hormone level would be more than 150. And so one way of being able to see whether, in actual fact, the progression of the pregnancy is going well is just to repeat the pregnancy hormone sort of 48 to 72 hours later. We normally would expect a doubling of the HCG every 2 days. So I suppose to get a little bit of reassurance, one thing you probably could do is just get a repeat HCG. Now, if you find that the pregnancy hormone's gone from 150 to 300, it's reassuring. You might want to do another one again. And if it's now 600, that's the time where you could possibly book in for a pregnancy scan and make sure that, that everything's going well.
Yeah. Yeah, so that's, I think, reassuring to know for a lot of people. So again, HCG question. With dating scans, do you go by HCG levels or first day of last period?
So I don't go by HCG levels. I mean, if the HCG level has risen well, I'm happy. Remembering that if a woman has a 28-day cycle based on last menstrual period, that is how we calculate the expected due date. But what actually, it's quite interesting, isn't it? So that if your period comes, let's say on the 1st of February, and then on the 28th of February, 4 weeks later, or 28 days later is when your period was due, you're 4 weeks pregnant. Well, in actual fact, you've only been pregnant for 2 weeks, right? So for the first 2 weeks of your period, from the time when you've actually had your period until the time that you actually ovulate, then you're not technically pregnant. So what happens is that if you have a 35-day cycle now, where you actually ovulate, instead of ovulating day 14, you now ovulate day 21. Well, then your period comes day 35. You can't simply add an additional week to the pregnancy. So you can't go back to the last normal menstrual period, which occurred 35 days ago. You actually have to cut back 7 days to recalculate when your actual due date is, or how many weeks you are. So in actual fact, if you know when you have conceived, i.e. you know when you've ovulated, then what you can do is use a pregnancy calculator that talks about conception date as opposed to last menstrual date. And that'll appropriately calculate your due date and therefore appropriately calculate when that first pregnancy scan is. Remembering that, generally speaking, we can see a pregnancy within the uterus once the HCG level's around 1,500 or 1,500. But in order for us to be confident that there's an ongoing and viable pregnancy, that will be done, generally speaking, at 6 weeks and 2 days, where we can see a heartbeat.
Yeah, I know that's always one my patients are looking forward to, seeing that heartbeat. Now, talking about the French women and eating soft cheese, can I get tested for Listeria infection?
You can. I mean, look, Listeria is very uncommon, of course. I mean, generally speaking, if you've got symptoms, we will test for Listeria. I mean, a lot of patients will have, they'll eat something where there's a high chance of Listeria, and then they'll go, oh my God, should I get tested? Well, there's no point unless you're developing symptoms. So at that point in time, if you had symptoms consistent, fevers, we would then go on and do blood cultures and the like. But I think just on spec, no, there's probably no need. Yeah.
So flying, how many weeks is unsafe to fly?
So, I mean, most of the airlines will have a specific time frame in terms of flying. Remembering that flying is safe, yeah? And certainly when you're pregnant, I used to have a lot of air hostesses who were my patients. Unfortunately, with COVID, we don't have many now. But we would normally suggest grounding in terms of them once you hit around about 34 weeks. So in terms of flying interstate, of course, I think most, if not all, airlines sort of suggest nothing after 36 weeks. I think the other thing you've also got to look at is the destination that you're going to. I remember when my wife was pregnant with our second child, I was studying busily for an exam, and we were in Fiji, and I think she was around about 20 or 22 weeks at the time, but there was a woman there who was 28 weeks. And I suppose at the time I was an O&G registrar, and I was thinking, geez, what happens if she went into labour here at 28 weeks? You know, the chance to resuscitate a baby on the Coral Coast in Fiji was going to be exceptionally low. So I think, yes, it's unlikely to occur that you'll go into preterm birth, but if it were to be, you'd like to be in a region where you know you can be adequately cared for. So I wouldn't be suggesting sort of going into a remote island. It would be sort of like, okay, well, we're going to go to Queensland. Well, of course, that's going to be okay, yeah? So go somewhere where you know that if things were to, in terms of your pregnancy, would be to be there'd be a complication, that you know you can be adequately managed.
Yeah. No, I think that's reasonable, safe advice. So question on licorice tea. Is it bad for baby in pregnancy?
I don't know specifically about licorice tea. You might be able to answer that. I mean, licorice in itself, I think, can have a bit of a hypertensive effect. It's got sort of like a mineral corticoid effect. I'd have to look that up to be 100% effective. There is actually guidelines in terms of herbal teas that whenever someone asks me, can I have this particular tea? I mean, I'm not au fait with all the different types of herbal teas, but you might know. Do you know?
Look, licorice does the same reason. If there's a hypertensive, I'm generally ultra cautious just because it does have so look at your blood pressure, your history of blood pressure, your mum's history of blood pressure, your personal one. Generally in a tea form, the dose is very low anyway. So if you're having a couple a week, generally, but if you're having one every day and you do have hypertensive problems, I would probably caution that. Go for a different tea. There are plenty available, and there is a great resource that if you are concerned about herbal blends, because there's so many out there. But yeah, in general, low dose amounts are okay, but just caution that hypertensive. Probably another one in my realm, other than folate, vitamins are important in early pregnancy.
Yeah, I mean, there's no doubt that in terms of minerals, that we do need to have a certain type. The two major ones that we are most concerned about, of course, are folate and also iodine. They're probably the two big ones prior to pregnancy that you need to be taking on a regular basis. And in terms of that, obviously, taking a supplement is going to be particularly important.
Yeah. So folate is obviously, a big one. Iodine, I check that in a lot of my patients, particularly if they've got thyroid issues. That is one that you want to get right prior to pregnancy. Vitamin D is another one I like to check. Iron, get your levels checked again and take a supplement that contains a good chelated form of iron, because it shouldn't constipate you. If it's being absorbed into your bloodstream, it can't be there to cause constipation. So if it's constipating you, it's probably a reasonably harsh form. So, and B12 is another one that I do check with most of my patients as well. So a good prenatal should cover that. If I know a lot of your patients are on that one as well. Isocyanate nutrients is my prenatal, but a good prenatal with your folate, choline, is another one, iodine and your B12, and then your other minerals should be a good combo.
And I think and then this is part of one of the reasons why a preconception talk is good, because most, if not all, and similar to you, will undertake all those blood tests before we head into pregnancy as well, and advise accordingly.
Yeah. So if you're thinking about you're not pregnant yet, go see Joe, go see someone who can do those bloods for you, and make sure your levels are healthy going into pregnancy, because it's a lot easier to get them healthy before pregnancy than when you're already being drained by blood during pregnancy. So look at issues around short luteal phase. Mine is 10 days. We've been trying for baby number 2 for 10 to 11 months. I have a 40 to 45 day cycle on that 10-day luteal phase.
Yeah, I mean, look, there are differing opinions on a short luteal phase, and I must admit I tend to treat with short luteal phase. On a 45-day cycle, there's two things to remember. Number one, that for every, if you look at 4 months, a woman on a 45-day cycle, or 3 months, for example, 90 days, a 45-day cycle, the opportunity to conceive is twice. Whereas a person who's having a 28-day cycle will have already had 3 opportunities. So already, in terms of trying to conceive, one thing I would be recommending is ovulation induction, in order to shorten the time interval from period to ovulation. And the next thing, of course, is the short luteal phase. if you imagine an embryo implanting in the uterus, and it needs a good 14 days to sit there, tack on, and start to grow within the uterus. But if all of a sudden along comes a wave and flushes it out, i.e. a period, well, then you can imagine that that poor embryo's got no opportunity to take hold. So in patients who present with a short luteal phase, I tend to, number one, confirm when ovulation occurs, and I tend to actually monitor the cycle. So some women may have a 24-day cycle and still ovulate day 14, so that's 10 days. And in those cases, I'll actually monitor when ovulation occurs by undertaking an ultrasound scan and then supporting the luteal phase with vaginal progesterone to keep the progesterone level up to allow that embryo to implant before there's that period to wash it out.
Yeah. I love that cycle tracking that you do. I know I'm able to support my patients nutritionally and then work with their periods to help to regulate their cycles and then get that tracking so we know exactly what's happening and when they're ovulating and what that luteal phase is doing. Yep. Is there any chance of conceiving naturally with very low AMH? So talking under 5?
Yeah, so I think I may have talked about this once. For those of you who don't already follow me, please do so, because I do every Sunday. I do what's termed the Sunday session, where I try to get try to answer as many questions as I possibly can in sort of a half-hour period. And I often talk about a low AMH. So an AMH, of course, is a view or a window into the underlying ovarian reserve of a woman. Now, you can have a very high AMH, as in a woman who's got polycystic ovarian syndrome, and never ovulate and therefore never become pregnant. Or you can have a very low AMH, ovulate every month, and of course get pregnant, because you only need one egg to conceive. So the biggest determinant then of whether you're going to conceive or not is, number one, ovulating, and number two, a woman's age. So the younger you are, the greater the chance that you're able to conceive naturally. I use a little acronym, and any couple that comes and sees me, I use this. Everyone leaves with a little sort of A5 piece of paper that sort of explains, my management in terms of what I think's going on. So the little acronym I use for fertility is SSROOP. You need to have sex. You need to appropriately time sex around ovulation. There needs to be sperm. Hence why, when a couple are coming to see me for fertility, if you're a single woman, you're coming yourself. If you're a same-sex couple, you're coming with your female partner. But in terms of, a heterosexual couple, the guy needs to come, into the appointment. So, you need to have sperm. The sperm has to be good quality. You need to support the sperm in terms of supplementation as well. You need a receptive uterus, so uterus that's structurally normal with no impediment to pregnancy. You need to have and that includes looking at things like bleeding, looking at pain with periods to determine whether there's anything like endometriosis, doing an ultrasound scan to confirm the uterus is normal. You need to have open tubes because of course that's where fertilization occurs, and you need to ovulate. And so they're the requirements for pregnancy. Not one of those requirements involves the AMH.
Yeah, I think that holistic approach is really important. I think I've got a lot of patients coming through with low AMH, age, and they're definitely factors, but they're one of a multitude of factors involved in getting pregnant. And I go way back to their mother's pregnancy when I go on my initial consultation, just to find out what life the eggs have lived and what your specific issues are. Because yes, that's just one factor. And yes, I'm sure you've had to, and I've had patients conceive with AMH of under 5. So a lot of factors to look at. So on the Pessaries note for that luteal phase support, how long do you recommend to continue the progesterone Pessaries?
So certainly up until you've had a positive pregnancy test, and then I tend to continue it up until 13 weeks, so 12 to 13 weeks. We know that the placenta starts to produce its own progesterone from around about 10 weeks. So effectively, by 10 weeks, we've already got, if you imagine progestrogen's like water, if we've got a glass and it's full of water, we're filling it up with progesterone in terms of water. By the time you get into 12 weeks, it's overflowing because, of course, the progesterone is being produced by the placenta. It's one of the very reasons why a woman can conceive and have a baby even when she's menopausal, because we support the pregnancy from the time that we're doing the embryo transfer or before, all the way through until 12 weeks. And then the placenta takes over all the hormonal function. So the woman no longer needs any progesterone or alternative estrogen as a tablet. The placenta continues to take things over. So until 12 weeks for safety, given the fact that we're trying to supplement the progesterone. Because in terms of, a bit of an understanding about why we call it the luteal phase, when an egg is released from an ovary or from a follicle rather, it's like cracking open an egg. You've cracked open the egg and the egg gets released. The eggshell then collapses on itself and forms something called the corpus luteum. And that corpus luteum is what then drives the progesterone production that occurs for the latter part of the cycle. But it's also particularly important in the progesterone requirements for early pregnancy. So the HCG, once the embryo is implanted into the uterus, the HCG continues to stimulate the corpus luteum to produce progesterone. And if we're already talking about a corpus luteum or the luteal phase, and that's where we get the name luteal phase from, if we're already talking about a corpus luteum that isn't supporting enough with progesterone, well, then we want to continue that corpus luteum support until the placenta takes over. So the corpus luteum will continue to produce progesterone and support the pregnancy until the placenta takes over.
Yeah. Now, I've got a number of questions coming in here, so we are probably going to miss some. I'm just scrolling through, mine stop. But there's a couple of questions about, we'll touch on that, anxiety. Stress and anxiety, a couple of miscarriages. How big of a factor is that, in your opinion?
Look, I certainly think that anxiety and stress plays a huge role in pregnancy loss and miscarriage, and it's probably something we don't manage well at all amongst ourselves, in particular as humans. I mean, we all have stresses and anxieties that, we bottle up inside before we eventually they are exposed in health outcomes. And, I often say to my patients, I'm very upbeat, and anyone who ever comes sees me knows that, I try to maintain an air of positivity. And even when we're doing an embryo transfer, for example, I'm making it as enjoyable an experience as we possibly can. So I do think that anxiety it plays a huge role, and so does stress. I'm reminded of the fact that there was and I don't know, this is sort of, maybe it's a myth, but this is what I got told, that there used to be a fertility specialist that whenever a couple would come and see him, he would have a map of the world behind him, and he'd say to the couple, before we start any treatment, and he'd pick up a dart, he'd throw it behind his back, and it would land on somewhere in the world, and he'd say, you need to go on a holiday there. Because, he was trying to say, stress is playing an important role in the fact that you're unable to conceive. So I think what you should do is just de-stress before you start. And it's true. I never try to pressure people to do any IVF treatment during the Christmas and the New Year period, because my overall feeling is that this is a time where there's a lot more frivolity, people are a lot happier. You're going out, you're meeting up with your friends, and Bob's your uncle. You're not thinking about trying to get, the 2-week wait. I always talk about women living in 2-week cycles. 2 weeks from a period to when you ovulate, 2 weeks from ovulation to having hopefully a positive pregnancy test, and then feeling let down that unfortunately you're not pregnant again, and then going back to do the 2-week wait again, 2 weeks again. So the fact that you then take your mind off that and relax, you come back pregnant. And so often, January is a great time for doing pregnancy scans, because a lot of people have not needed anything in order to conceive. So I do think stress and anxiety plays a role. It's one of the other reasons why I think, as a fertility specialist, I know my limitations. And I've said this to two patients today, when they talk to me about acupuncture and they talk to me about relaxation and meditation. I said, I know full well that when you come and see me, I give you as much emotional support as I can give you in a 15 or a 10-minute consultation, right? When we're doing an ovulation scan, it's not a proper sit-down consult. Yeah, the first consult's 30 or 40 minutes, but when we're doing scans, it's 10 minutes. And so I can't provide you, and I don't make excuses necessarily, but I know that I'm not I don't have the capacity to do that with the time that I have. But I know that there's like a village of people that you need to, rely upon. People like yourself, Tasha, but acupuncturists, masseurs, chiropractors, physios, a whole range of people that can support you, your friends, your family, that can support you through the emotional journey. And I talk about also in terms of IVF for couples that IVF is a physical, a financial, and emotional journey. And I never want a patient to get to a point where they're taxed out on any one of those three things, whether it be physical, whether it be financial, or whether it be emotional. And we need to be very conscious of that. And I think a good fertility specialist will actually say to a couple, hey, look, enough's enough. And part of that might be enough's enough utilizing your own eggs or your own sperm, and let's consider using donor eggs or donor sperm. But it's also about having restraint. As I said, I'm very optimistic, and I always give, I always try to be positive with my patients, but there's also a point in time where you do need to realize the emotional burden that thinking about fertility all the time has upon an individual.
Yeah, it's really, you do need the village. And they say it takes a village to raise a child. I did see a post the other day saying it takes a village to create a child and a pregnancy, and it really does. So you don't need to do it alone. Make sure you are getting that support around you, around that stress. And I did, on that note of that obstetrician or that specialist that you saw, there was a study that I love that I often quote to my patients, that the women who were entertained by medical clowns post-transfer had better pregnancy success than those who weren't. I mean, whether that study is able to be replicated, but I think it just shows that positive mindset, those lovely positive neurotransmitters flowing through your body at that time. So I always say to my patients, go see a romantic comedy, do something fun with your husband, do something lighthearted, just, not that stress and anxiety that you were mentioning.
Yeah.
So here we go. I'm going to get, we've got a question here. Would you recommend IUI for unexplained infertility?
So again, without knowing the specific circumstances, so unexplained infertility is where, of course, we have no medical reason for a couple being unable to conceive. Now, remember that the chance of pregnancy per month for a couple starting their pregnancy journey or their fertility journey is 20% per month. So that by the end of 1 year, approximately 80% of those couples will be pregnant, which leaves a cohort of 20% of couples who aren't. And the reason why that is because it's cumulative. So if we start off with 100 in January, by February, 20 of them are pregnant and 80 aren't. But it's not like another 20 get pregnant. It's 20% of the remainder. So in February, of those 80, 16 get pregnant, leaving 64, and then 12 get pregnant, leaving 52. So that's why you get down to 20% after 1 year. So that means in the second year, between year 1 and year 2, a further 10% of couples get pregnant. So now we've got 90% of couples who are pregnant after 2 years. So between year 1 and year 2, your chance of pregnancy per month is 1 to 2%. It's pretty low. And this is partly one of the reasons why it's particularly important to seek out the advice of a fertility specialist if you're under the age of 35 by that 1 year mark, and if you're over the age of 35, certainly by 6 months. Now, in terms of what we can do in order to improve the chances of pregnancy, if we're saying that naturally trying to conceive an unexplained fertility, your chance of pregnancy after 1 year is 1 to 2%. If I were to give you medication where I stimulate the ovaries just a little bit, possibly to get 1 or 2 follicles, and this is in ovulation induction, I'm increasing the chances by double, right? So rather than 1 to 2%, it's now 2 to 4%. IUI does give you a modest increase, but it is modest. So in other words, if you were to do IUI, you're probably going to get the chance of pregnancy up to around 10%. And that's on the basis that we're now putting the sperm further up into the uterus and allowing those sperm, you got to think about those sperm as little marathon runners. And, we're sort of giving them a bit of a head start to get closer to the egg. But it's not a huge difference, right? 10% is not really that much per month. If you were to do IVF, then for a young couple, the chance of pregnancy would be in the order of 30 to 40% per cycle. So when you look at the cost economics and also the time to pregnancy, if I had two couples, one couple, this is the IUI couple, one couple had 10% chance in the first month and this couple had 30 to 40%, you can see we're already behind. And so if you did another cycle, well, that's getting you up to, let's say, even if you said 20%, but it's not, and then this couple's up to 80%. So we're leapfrogging them all the time with IVF. So yes, IUI might be cheaper, but in order to get to the point where you're pregnant, where you've got near enough an 80 to 90% chance of pregnancy, you're probably doing more cycles of IUI, and as a result, you're probably spending more money. Now, forget about the money. Again, I talked about before the taxes upon you in terms of yourself, both physically and also emotionally as well. So, every month you're going through the same roller coaster of trying to become pregnant as a couple. And it's not lost upon me that they're particularly in either a same-sex couple or a heterosexual couple, that there is the other person involved in this. And so it's not just the woman who's going through treatment herself, but of course it's her partner, and the strain that has on the relationship is enormous.
Yeah, I think it's good to acknowledge that too. And I'm glad we talked about the stress of infertility, because it is such a difficult journey. It's an emotional roller coaster, and getting the support around you through that and taking the best outcome and seeing a specialist. I do love the fact that you do the investigations that people need to. I find that really beneficial, that if you haven't seen a specialist, do go and get the workups, do go and get the blood work to check what's happening and what the reason is that you're not conceiving. Because it can be simple sometimes. I've got a few questions coming through here. One about hypermobile dislocating hips. Can you deliver naturally? Yeah,
I mean, there's no. I mean, I think sometimes physiotherapists might say that you're going to put undue stress on the hips. I mean, at the end of the day, assuming there's no added risk in terms of fracture, which there's not going to be, the fact that you've actually got hypermobile hips is actually proof positive that the pelvis is more than capable of being able to manage the rigors of childbirth. So I can't see why not. But again, this is a decision that's done in consultation with yourself and the other care provider that you're normally seeing in terms of the mobile hips as well.
Excellent. So if I've missed a question, please feel free to dump it at the bottom again, because I've realized it stopped again. So there's a few coming through. Oh, you guys are fertility godparents we never knew we needed. God bless you both. Yes, lovely. Thank you, guys. We're really happy to be here helping you. So there's another question I had come through here. I'll just scroll back. Baby's head, way off the charts at 20 weeks. It's true that my body won't is it true that my body won't make a baby too big for me to have a natural birth? Is that true? Or we need a Caesar for a big baby?
Okay, so look, historically, there's a couple of things just to sort of, this is a big comment. So I'll start off by saying that, historically, this whole adage of opposites attract is probably a little bit of a misnomer, because back in the old days when we had limited ability to travel, we actually married someone or shacked up with someone who was geographically located very close to us. So our genetic pool in terms of our babies was very similar to us. And of course now, particularly in a multi-ethnic diversity that we have here in Australia, we are getting different genetics. That said, generally speaking, if you are the way that humans, fortunately, we want to continue to propagate our species. So of course, in order to do that, we need to have a baby born through the birth canal, and we also need to have the mother alive after it. I mean, that's the ultimate goal of procreation. So genetically, the baby should fit down the birth canal of a mother. Now, in saying that, of course, that's why it's unfortunately cesarean section. Well, not unfortunately, but while we've got cesarean section, modern day obstetrics realizes that that's not true for every single woman. And it is difficult for us to remember because, of course, none of us have been around that particular time, but an era where women died in labour and babies died during labour because of the fact that there was long, protracted labours with increasing levels of infection, bleeding post-birth and stuff like that. So we're in a very fortunate situation, of course, where if labour doesn't progress to the point of a vaginal birth, which is the ultimate goal, then a caesarean section can easily be done. One of the things to say is that, you know, if you were to mate a Shetland pony with a stallion, that the foal, generally speaking, comes out the size of the Shetland pony, even though when it grows up, it might be halfway between mum and dad. The other thing to also make mention is I use the analogy of the pelvis being like a basketball hoop. And if you imagine the baby's head is a basketball trying to fit through the hoop. Now, before you go into labour, the basketball may be too big to fit down. So the baby's head may be too big to fit down the birth canal. But during the process of labour, the bones within the baby's skull can actually mould over one another. So if you imagine a basketball or a netball, and you know the black bits that sort of hold the leaves of the basketball and the netball together, imagine they fold over one another. Well, as a result, you could potentially shrink the diameter of the ball. And so whilst initially before birth, the ball won't fit through the hoop, if you've now shrunk the diameter of the ball, then the ball will fit through. So the true test of whether you're going to be able to labour and be able to have a baby vaginally will be ultimately to go through birth itself. Now, of course, as you approach your due date, there'll be subtle signs that that's a possibility, and that'll mean the head has actually started to engage in the pelvis. If by the time you get to a point where it's necessary to have baby for a range of reasons, and if the baby's head remains quite high and not engaged in the pelvis, so the basketball hasn't sort of made its way through the hoop so that it's locked in there, well then yes, possibly a caesarean section may be on the card. But to be honest, the true test of whether you're going to go into labour, whether you're going to be able to birth a baby vaginally is actually undertaking a vaginal birth. And look, in my own clinical practice of women who wish to have a vaginal birth, whether they're induced or alternatively they go into labour naturally, my emergency caesarean section rate sits anywhere between 9 to 15%. It sort of hovers around that time, that range every month. Now, a lot of people will be surprised by that because they would think that, well, you know, in private practice, I hear that every woman will end up with a Caesar. Well, that's not true. I mean, quite clearly, 9 to 15% is not a high caesarean section rate. And that would be consistent, or if not better than what the WHO recommends, and certainly consistent with, you know, some of our public hospitals as well.
Yeah. So hope that's been a good answer to that question. That makes a lot of sense. So there's a question here about getting pregnant again. So natural killer cells. Can you get pregnant with high natural killer cells?
Yeah, I mean, the simple answer to that is yes, yeah. So in terms of natural killer cells, there is a distribution. You know, there's going to be some women who, if you remember your mathematics and all that sort of stuff, or statistics, there's going to be a distribution curve, and there's going to be some women with a very low level of natural killer cells. The vast majority will have just a normal level, and then some women will have a high level of natural killer cells. The jury is, despite increasing evidence, the jury is still pretty much out in terms of treating natural killer cells, investigating for natural killer cells. But we probably know, and look, it's somewhat anecdotal, that women who are having problems trying to conceive, or if they've got an issue with miscarriage, or if they're having recurrent implantation failure due to IVF, that probably the subset group of those women have a higher amount of natural killer cells. So you can still conceive, and in the general population, probably, who have no issues with fertility, there's probably women, in fact there has to be women getting pregnant with a high level of natural killer cells. The question then is, if we find it, and if we're having concerns with recurrent implantation failure, miscarriage, should we treat it? And that then becomes a discussion with your fertility specialist, obstetrician, gynecologist, and yourself. And it's always a matter of balancing up the risks of treatment versus the benefits. And if you as an individual are appreciative of those, you can make an informed decision.
Yeah, I think that's a good summary of that. And I did a podcast on that topic actually with Professor Sarah Robertson, who's doing research into fertility and the immune system and the role of the immune system and obviously natural killer cells in the establishment of a pregnancy. So that's at tashajennings.com.au under the podcast tab. Yeah, Professor Sarah Robertson, she has also some tips on what you can do to help balance and create a receptive environment in regards to your immune system. But yeah, NK cells, definitely we can create pregnancy here. So does a shorter cycle, we're probably going to have to wrap up shortly, does a shorter cycle, so average 26 days, ranging 24 to 28, negatively affect fertility?
No, I mean, again, we talked about the short luteal phase. As long as you're ovulating, so for a 26-day cycle, you should be ovulating day 12. So unless you're ovulating day 14, 15, 16, and then having a 26-day cycle, then that's a short luteal phase. That would have a negative impact in terms of pregnancy. Well, some of us believe it has a negative impact in terms of pregnancy.
Yeah. So it's really all about ovulation. And someone else has got here, what about ovulation test kits? How do I know when and if I'm ovulating?
So I would like to have shares in Clear Blue. I often say to my patients, don't waste your money on ovulation kit tests. Spend them on a night out, you know, spend it on something special for yourself or your partner. Don't spend it on Clear Blue tests. If you are having regular menstrual cycles, as long as you're having, so what I mean by that is 28-day cycles, as long as you're having sex every second day from day 10 through to day 20, you will cover the fertility window. Whether you pee on a stick, again, all it's doing is increasing your stress hormone levels and creating a level of anxiety that's not warranted nor needed. So just enjoy each other's company. Don't be time pressured. It's got to be on the clock. Oh my God, I'm ovulating quickly. You know, it becomes a job otherwise, making love and trying to have a baby.
I agree with that one. I did a live with a sexologist for that reason, because I find couples are timing it, and yeah, we have to do it now, and the poor partner is really struggling to actually create the environment to make that happen. So yeah, look at it when you're ovulating, if you're having a regular cycle. And there's also I look at fertile mucus and other signs that you can see yourself to help you, rather than Clear Blue. So there's a few questions still coming through. I'll try and cover off a last one. Is insomnia in early pregnancy normal?
Yeah, it is. Look, I have many theories as to a theory as to why. I think at the end of the day, in part, well, first of all, feeling tired and lethargic is definitely a symptom of pregnancy. And if you think about, if we were just primates in the jungle before we're as a woman, we're wanting to become pregnant, we're heightened and we want to find a mate. Eventually we find that mate, we get pregnant, we're not interested in anyone anymore apart from ourselves and nurturing ourselves and looking after ourselves as a woman. So that's in part why you start feeling tired. Of course, the extra demands that are placed upon us in terms of living in 2021 and the societal demands of what it is to be a woman, still in this world. If you're a working woman, for whatever reason, you still have to go home and cook, clean, wash, iron, and your partner probably doesn't do that. So there's all those societal demands that are placed on us. So you do feel tired. And then the next thing is, of course, insomnia. Well, I sort of liken it to the fact that your body's in training for what's ahead. And there's no doubt that once that baby's born, it's going to have a bit of demand on you in terms of nighttime. And I think part of the way that we've evolved is to prepare us, particularly to prepare a woman, not so much a bloke. And this is probably one of the reasons why blokes just sleep through a baby crying. But prepare a woman to be, not happy is not the right word, because no one's happy to wake up in the middle of the night, but to be accustomed to waking up in the middle of the night to care for a baby. So part of that then is this insomnia that sort of creeps in during pregnancy, so that you are prepared. It's interesting, well, as I said before, I've got a 2-year-old daughter, but my phone can go off, my pager can go off, and I'm bright-eyed, bushy-tailed. Yep, okay, cool, and I'm off to catch a baby. But when my daughter was was at home crying in the middle of the night, didn't hear it.
It's funny, I think that maternal instinct kicks in. I had the same in our house here. I was up at the drop of a hat, and yeah, my husband could sleep through it. So maybe there is something in that maternal
Definitely.
genes that kick in during pregnancy as well. So a couple of final questions. Is there any implantation symptoms?
Yeah, some women have implantation pain. Look, I remember there's countless of stories of women who we put in an embryo and they just know the embryo is implanted. They can tell. Even though the HCG is not going to be detectable in their body. But some women just intuitive, and they're intuitive enough to, and they're in tune with their body that they can determine the subtleties in terms of a implantation. So, if you are in tune with your body, and particularly your menstrual cycle, and when you ovulate, there's a possibility you will know when implantation goes. Oh, happens. Sorry.
Yeah. So last question, spotting during early pregnancy. What are the reasons? Is it normal?
Yeah, look, around 25% of women will experience some element of blood loss during the start of pregnancy. And I always say to my patients, and when they ring me up in the middle of the night, anxious about some bleeding, and I say, look, we'll do a scan in the morning. I remember there was a woman who Sunday morning paged me because she effectively lost almost 250 mils of blood. And in fact, I remember her bringing up a glass jar full of blood because she thought she'd lost the pregnancy early on. And we did a scan and everything was fine. So you can lose blood. And what I say to you is, if you lose blood, don't lose hope, because there is still a possibility that pregnancy can be there. You got to remember that during pregnancy, there is an increased amount of blood flow that occurs not only to the uterus, but also to the cervix. And as a result of the cervix has got these little blood vessels. And the cervix is, if you imagine the cervix is like a cone, the outside of the cervix has got tough skin, but the inside of the cervix is very much similar to the inside of our mouth. It's got glandular tissue, and that glandular tissue will actually migrate out to the surface of the cervix during early pregnancy. And it gets affected by the acidity of the vagina. And there's little blood vessels circling all the way through that little mucus, or those little glandular cells, which can bleed. And that can sometimes set up a bleeding response. So often it's just the cervix that's bleeding, or it could be from the vagina, and maybe not necessarily the pregnancy.
So good note to end on. I think that's a lot of people have concerns around that. So if you've got any further questions that we haven't covered today, I know Joe's always open to answering questions, and feel free to shoot any questions through to me. If you want any free resources to help you fall pregnant, jump on my Instagram at tashajennings.com.au/checklist. You've got a free checklist there. And be sure to follow Joe if you haven't already. He does amazing Insta Lives, always on Sunday. So thank you so much for taking your time out of your busy and emotional day today to help everyone here with their questions.
No worries. Thank you, Tasha.
Excellent. Thanks, Joe. Bye.
Bye for now. Bye.